Hello, we are so excited to announce the Senior Spotlight, a brand new podcast by Concierge Care Advisors. We are a care and transition company helping seniors find housing and care. My name's Mary Cordova. I'm the co-founder of Concierge Care Advisors. This podcast features industry experts who are dedicated to assisting seniors and their families wherever you are, whether you are a caregiver, an adult child, a senior, or an older adult, seeking resources and navigating the complexity of aging. The Senior Spotlight is your go-to source for education and support. Each episode will explore crucial topics such as navigating senior living options, financial planning, senior care, health and wellness, and legal challenges, veterans benefits, and much more. Today, I have the pleasure of introducing two doctors from our Physician Advisory Board, Dr. Alex D. Moraes and Dr. Brian Ferris. Welcome. Thank you for being here today.
Thank you. Thank you.
Go ahead and share a little bit about who you are, and I will let you start, Dr. Alex.
Thank you. Excuse me. I'm a family practice physician. I've been in medicine 27 years. And I currently work in a concierge-based practice, but I've worked in traditional practices. I was the medical director of 5 nursing homes. I'm currently a medical director of a hospice group, and I own a palliative care company. So throughout the years, I've taken care of the spectrum of life from birth till death, and now find myself caring more for the elderly with an aged population, which is where we're transitioning. We're seeing a lot more people.
We're so lucky to have you on our physician board, having such great experience with the nursing home, the hospice, the end of life. So wonderful to have you here. Dr. Brian, love to hear
Thanks.
a little bit about you.
Well, the name is Brian Ferris, and I'm a vascular surgeon, also trained in general surgery back in the era when I trained. And I've been in practice since 2003. And as a vascular surgeon, we classically take care of advanced arterial diseases outside the heart. So we take care of the blood vessels from the base of the skull all the way down to the foot. And our practice had the pleasure of having an interest not only in taking care of those problems, but all the supportive care that goes with it. So that gave us a lens to look upstream at the risk factors that led to patients getting to those advanced diseases, plus an interest in our lexicon of our specialty of venous diseases and other problems gave us the pleasure of seeing patients of all ages. And I think the biggest wisdom that I've learned is the importance of looking upstream, whether it's from a medical perspective or a social or family perspective, and how that influences outcome later in life. And one of my mentors, the late John Porter, way back when in the 90s, predicted that we will be seeing a tsunami that we are totally unprepared for when it comes to aging. And I think we're starting to see the crest of that wave, or at least that wave build now.
Absolutely. I think we see that now with people that are aging in place, and whether they're at home or needing to make a transition, definitely seeing those numbers increase and the needs increase. So again, doctors, thank you so much for joining us today. Today we're going to talk about the importance of legal documents. We know this is an important subject for both of you, and on my side as well. When we're helping find seniors housing, we need to have a medical power of attorney, financial, etc. But we would like to know a little bit from you two. Why is it so important to have a POLST and a advanced directive? And we want to talk a little bit about that and financial power of attorneys, so people can be abreast of decision making and be in control of their destiny. So either one of you.
There's a little bit of a difference in how both myself and Brian address. Brian has done a lot of the conversations before surgery, during the hospitalizations, and sometimes upon discharge. And I, as a family practice physician practicing in a traditional office, I'm working with the everyday concept of when they're not experiencing the crises that leads them down the road to a vascular surgeon.
Right.
Many times people it's interesting because they don't want to have the conversation for whatever reason. And in this country, I think the conversation about end of life, death and dying, and what we want done has been avoided, and people are becoming more open. There's also a big misunderstanding of what organizations like hospice and palliative care can do to support you.
Right.
Because many times we think that just because I went on hospice, I'm going to die.
I'm going to die, right.
And it doesn't mean that. I've had a number of patients that come on hospice and all of a sudden they get better care.
Graduate off, right.
And they graduate off of hospice, which is pretty impressive, which is kind of neat.
And we've seen that in clinical data.
Yes,
Oh, yes.
it's absolutely true. And I've had a number of patients that have done that over my last 11 years of working in hospice. Typically with all my patients, I begin the conversation with, what are your wishes if something happens to you? You get sick, ill, are unable to live in your current environment. Maybe you have to go to an independent living, an assisted living facility, or skilled nursing. And we think it doesn't happen. And my neighbor, for example, just down the street, I took care of him recently. He didn't expect to get ill, but he ended up getting sick, going to a hospital, discharged to the nursing facility that I was the medical director of. And I now was in charge of his care. And I had a conversation with he and his wife because his primary care physician was not in the facility.
Sure.
But, I try to, at every visit, ask people, what are your wishes? The POLST form is a complicated document, but it's quite easy. And sometimes there's a misunderstanding of what the two sections mean. And they do mean different things in somebody who's in the hospital at times versus on an outpatient. And it's really to convey your wishes to both the medical community, your family, of what you would want done if you were to, for example, have your heart stop breathing. There's one section. And what that does is if you make choices of whether you want to be resuscitated or not, it takes all the pressure off of your family to make those decisions for you and allows them to now honor your wishes. There's another section that says that if I'm ill, do I want to be hospitalized? Do I want to be intubated? Or do I just want comfort care? And that's an important conversation to have with somebody who, with a physician, because they can explain to you what each one of those choices mean. And once you make those selections, I always ask patients to have a conversation with their family members to let them know that these are truly my wishes, because sometimes there will be 2-3 family members that may have different opinions.
Right.
But it's really honoring the person's wishes to make sure that we do what they chose,
right,
in case their health changes.
And that's that bright green form that is filled out, correct?
It's interesting. It's green here. It's pink in California.
Oh, interesting.
But I'm 60 years old and I have a POLST form, and I've had a conversation with my wife on what my wishes are, and we think, oh, I'm young, nothing's going to happen to me, but I could develop a meningitis, I could get in a major motor vehicle accident at any time. And then it takes the pressure off my wife to make the decision.
Absolutely, and knowing what your wishes are, so important. Dr. Ferris, anything you would like to add to that?
Yeah, sure. My view on this actually started really in medical school. I went to the University of Virginia, which has a very strong family practice and really pushed primary care in the early 90s. And one of their big pushes was the conundrum of providing more and more life support care, intensive care, tracheostomies, feeding tubes, and so on and so forth, and really diving in in a university medical school setting of the big questions of, is this right? Is this what we want? Is this what your family member would want? And so we talked back then about advanced directives, and it has evolved, in at least regionally here, to include POLST. And there was a book that I recall that came out in the mid-90s by, I think he was a cardiothoracic surgeon named Sherwin Newland. And he really kind of looked at it through clinical eyes to help understand where people were coming from in terms of their wishes and whatnot. And I think that we made really good strides. Sadly, I think we've slipped a bit. And I am very supportive of POLST. And my lenses on it, Alex is right, are that in the surgical setting, particularly with what I do, which can be immediately life and death with a ruptured aneurysm, there's a place for that. But also in my practice, there's been a place for it for patients that have chronic diseases that may or may not progress. And I think we've slipped a bit because we're all, for a variety of reasons that we're not here to point any fingers, we're all pressed for time beyond comprehension. And there's a lot of turnover. And these conversations require a relationship to help have the time to explain what that means, understand what that means, as well as have those conversations with families. And with 20, 30 years of in practice and in training, to watch who's my own sort of personal observational cohort of who's thriving, it's those who've had those conversations.
Yeah.
And with their family, and it always tends to make things better. But when the rubber is hitting the road, I learned long ago from some great mentors that to remind them that when their loved one, who's there on the gurney, they're not making the decision for them. They're voicing the wishes that they want when they can't.
Right.
And that helps a lot, but that's not always done.
Right.
And so when you go down that path where these things aren't thought through, not just clicked on the EMR, but when they're not thought through, it's always harder.
Yes.
And so again, the more upstream we do that, I think other things start to fall into place where you can start thinking and planning, and the conversation starts to get easier.
Yeah, I think you're absolutely right. And having those conversations, I've had a patient call a family member and so mad that an emergency department came to the house, ER, and basically went to keep them living, 92 years old, and, broke mom's ribs, etc. Sure. But the POLST form was nowhere to be found, so of course any medic is going to go and save a life, right?
Well, I think they have an obligation to. I think Alex can probably reflect on this. Some physicians and clinicians will say, put your POLST form in an envelope and write POLST and tape it to the refrigerator.
That's what we're told. Is that what you're told?
Yeah, it's always on
your
the side
patients?
of the refrigerator.
Yep.
Excuse me, on the
Wonderful.
side of the refrigerator, they can either tape it or put a magnet on it. And you're right, because if the form is not available, the emergency services will
They're obligated
to do full resuscitation.
Right, full resuscitation.
Right. I think what's important to emphasize too is we always talk about advanced directives, but the advanced directives is a different form than the POLST form. The POLST form is the immediacy of, I explain to my patients, if I were to walk out of the room and come back 5 minutes later and you were on the ground, no heartbeat, not breathing, basically you were clinically dead, would you want me to attempt to resuscitate you? And most of the time I get, what do you mean I'm dead? So I'm trying to emphasize the point because that POLST form is mainly utilized when somebody gets called, EMS services gets called to somebody's home.
Right.
We don't know how long they've been out. It could have been 5 minutes, it could be 10 minutes, it could be 1 hour.
Right.
And what occurs is the older you are and the more illnesses you may have, if we attempted to resuscitate you, your chances of coming back the way you were decreases significantly. And that's an important...
Exponentially.
It's a huge number. Right. The other thing I emphasize too is I have family members talk to their mom and dads and say, let's talk about a POLST form. Dr. Moraes did it for me. Can we? And sometimes they get met with, I'm not interested in conversing about it. But it's nice because at a future visit, I'm able to have that conversation. And one of the things that I let them know is, basically the way that if you don't want this form filled out, it basically means that your full code on both sections, it means that somebody comes out, they will definitely attempt to resuscitate you no matter what. And then the advanced directive is the form that's utilized after you've been in the hospital for a period of time, after they've addressed the acute crisis. That's when that form starts kicking in on what you want with your wishes, which includes things like artificial feeding, long-term use of ventilators, tracheostomies. So those forms that really have two sections, and I didn't understand it until I learned more about it. But Brian's right. It's a conversation that takes time, and typically when I have this conversation, it's 15 minutes out of my visit to do it correctly.
To really do it correctly.
It really takes time.
And often 15 minutes is an entire visit.
Yeah.
The way some systems are working, and again, it's not pointing any fingers, but when I think about it, if you're lucky, and you're not going to necessarily change culture across the board with a podcast or 1,000 podcasts, those at the family level or some other social input, whether it's somebody else that they have a relationship with in the community, whether it's at a place of worship or something else, or with the doctor, there's many options, but the more that individual can think it through, I think the closer you're gonna get. So to do the right work, it's a long, slow road,
Right.
but it's really, really important because we're pressed for resources more than ever. COVID's the crisis of COVID is well over, but at least around here regionally, we're still stressed.
Yes.
And I think that's because we're starting to see that demographic wave where people are getting older and sicker, and we've got to think about this more.
I absolutely agree. I recently had a conversation with my mom during COVID. She went into the hospital with a urinary tract infection, and she needed a blood transfusion. And they presented her the POLST form, and she said, "Nope, I don't want any, life measuring events to happen to me." But one of those was an antibiotic on that form. And it was like, "Mom, you just received an antibiotic. Now you're all better. Do you not
Right.
want that going forward?"
Right.
And so,
And
I think
usually that means, but I didn't mean that.
right, exactly.
And that's okay, because the form is always changeable.
Right.
But again, it boils down to the common equation of time and context to have it, right? I don't want to live on antibiotics to keep living.
Right.
I don't want antibiotics when it's futile.
Mm-hmm.
So that starts, as Alex said, starts segueing into advanced directives to have futile supportive care. So it's kind of, and we were talking about this, of course, as we were setting this up. Alex had a great analogy. One of the documents is the seatbelt, one is the airbag. And it's there to help protect you against harm that you don't necessarily want, but they work eloquently together in that kind of context.
Yeah, and the POLST form is your voice when you can't speak. That's how I
great.
sometimes explain
Right.
it to people.
Mm-hmm.
Because if you can speak, that POLST form is not yet a living document because you're able to express your needs.
Right.
So even if my POLST form says do not resuscitate, comfort care only, which means basically just keep me comfortable, no aggressive treatments, no hospitalizations, no antibiotics. If the ambulance were to come out and I was having some challenges and I said, yes, please take me to the hospital, I do want some treatments, then that document is null and void at that moment.
Right.
And that's what people are afraid of. They're
Right.
afraid that once they sign it, it's permanent, but it's not. It's really your voice when you can't speak. If you can speak, that document has no true meaning, and you can change it at any moment. So.
That's cool.
Yeah, and I think that's a really great point, and I think that's something that should be reminded not only on the individual patient client, but also really on the clinician side, that it is not a hard stop, and
No.
and there could probably be drift there on both ends of that conversation.
Yeah, living document that can be changed depending on where you're at in your journey. I like that. And you also mentioned, Doctor, having all of this in line really is putting somebody in control of your destiny. If you share some with your loved ones and your power of attorney what your wishes are, so somebody can advocate for you when you're not able to advocate for yourself. That's so huge.
That came up, actually. I think Alex said that, and
okay.
it's just and I just reiterated it. I think it's brilliant of being in control of your destiny.
Yeah. It's, for us, it's really important for people to understand that from the moment we start school, we're taught to treat and save and treat and save and treat and save, right? And that's what we do in our entire career.
Right.
So when somebody comes in, sometimes no matter what age, what illness they may have, we
Want to fix it.
want to fix it.
Yeah,
We're fixers.
right.
And if we have that form, then we can honor that person's wishes and stop trying to fix them, and then allow them the comfort of their wishes, whatever that may be.
Absolutely.
So when I trained, I did my general surgical training in Portland at Oregon Health and Sciences University, and I rotated through over 6 years, 7 hospitals or so, 2 level 1 trauma systems, and I had one surgeon graph it out very eloquently. And he said, it's really straightforward. And he drew out a curve, and it had a steep upward slope. This is when you learn how to operate. And then over time, and that's during your training, and then after training. But then over the course of your career, a much shallower slope is learning when to operate. And then the nearly flat curve that takes the longest time to grow is knowing when not to.
Not to. Interesting.
And that stuck with me a long time.
That's
A
interesting.
long time. And knowing when not to do things is really hard, because you not only are trained to treat, you're also trained to have data. You don't always have the data, and you do the best that you can. And I think it's also coupled by experience of it's not just a clean fix, that there's a lot of things that go with it. And so in the world of vascular surgery, when it pertains to limb salvage for arterial disease, diabetic neuropathy, there's a lot of heroic attempts that are fantastic to try and save a limb, but they may not necessarily have a good limb. And then in the end, is it really success for them to say, I never wish I went through that?
Yeah.
Or now I have a limb I can't use. And how do you measure that from success?
Right.
And so again, some of my mentors started shifting to think about the patient-centered outcome, right? Not our clinical definition of outcome, but what's important to the patient. And then that circled back again from one of our colleagues who gave me some personal advice when I was dealing with my aging parents of don't forget to ask them what's important to them. And it really helped provide that clairvoyance that I needed to help them make those decisions.
In that conversation, sometimes I ask family members to leave the room.
So they can be candid.
Because, well, a lot of times, mom and dad will answer the question based on the opinion of a child.
Right.
Or they'll begin to answer the question, and the child will say, no, Mom, we don't want you to have that. Right. You know, and they're influenced, and they'll switch their desires to what the family wishes. And sometimes that can now create, it creates some challenges in the family dynamics, because different family members may have opinions. So it's a good conversation to have independently, and then you bring the family in and you explain the choices that the person made.
Right.
And it changes the conversation.
And hopefully they can come around and honor that. On the power of attorney side and the medical and the financial on our side, when we're helping transition someone to a new environment, it's imperative that they have a power of attorney for medical, so someone can make medical decisions for them, but on the financial side as well, to make sure their bill's being paid. We just recently had someone dumped at the hospital that didn't pay their bill at an adult family home for 10 months, and the provider just could not continue to let that go on. So at Concierge Care Advisors, we always make sure that every patient, even if they're alert and oriented, that they have a medical power of attorney and a financial. So we can, just make sure that everyone has their ducks in a row, and that we're setting them up for success in their aging journey.
And I think there's a lot of assumptions that when somebody goes through an illness, a hospitalization, that the social worker or the case manager, so on and so forth, will do that. Well, they've got 1,000 other things to do.
Yeah.
And it's not unusual from my perspective to hear you say, well, it's just not done. And again, I think when we've had these conversations, and I've thought about that, well, who is to do it, and when should it come up? Does it come up during your taxes? Does it come up at the doctor's office? Does it come up anywhere in between? And the answer is it just doesn't come up.
Right.
And it really
doesn't come up enough, no matter what, right?
It really should come up a lot.
So part of my part of my history is, because we talk about past medical history, past surgical history, and family history. I also ask financial history. And people are taken back by it.
Right.
Because they're like, well, why do you want to know about my finances? And my simple explanation is that I'm trying to get you the best care that I can. And if I understand your finances, whether they're average, low, high, that helps guide what I can and can't do for you.
Mm-hmm.
Because, for example, I used to work in a community health center a long time ago. And there are a number of services out there for people who are getting care either through assistance or through a community health center or through a low-income process. And it's easy to qualify them for those services if you understand their needs, right? But I've also had extremely wealthy individuals not want to pay for stuff and then want services because they pay for their insurance, right? And their perception is, well, I pay my insurance company, I should be able to get that.
Right.
The reality isn't so. There's things that aren't covered, and there's items that you're technically responsible for if you don't qualify for those services. And I don't want to spin my wheels and waste my time if I don't understand your needs. So it's an important but challenging, and I tell them that I'm not going to share this with anyone. It just helps me take care of you.
I think it's a great point, because through a medical lens, having an idea helps guide your conversation as to the suggestions for treatment. Also include, where do they go? Who's going to take them? Do they have that relationship with their family? Do they need, when we started, there was no, for example, wound care clinics. You taught the family how to do it.
Right.
And the best wound care, in my opinion, is family that are involved. Now can be a lot more technically sophisticated these days. But the point goes to that when you get that, for us on the clinician side, history, and you can find out where they can go, and they have family support or not, then you can start to guide and set things up. And if we're planning an admission or it's an emergent admission, one of the first parts of your admission is to start thinking about
the discharge. Absolutely.
And so, Alex, you're totally right that you've got to have some insight. And again, it's always easier when it's planned.
Mm-hmm.
It's easier when it's planned, and it's easier if there are either a lot of finances or no finances. The challenge is always in the middle. The middle is always the big challenge.
Right. For us as well.
Right.
Absolutely.
And those forms now, it used to be very difficult to complete those forms. You had to go find a lawyer, somebody who specialized in it. They all had to be notarized. And now you can go online. There are programs that ask you questions, and at the end they complete a form, and then that form is just taken to a notary and notarized, so there's technically not very much cost. And those do hold water in the case of being
but those are also really technical things that in at least the current population who may need that the most may not know how to do that.
Absolutely.
Yeah.
Absolutely.
But to your point, Doctor, on the power of attorney for medical, you don't need that to be notarized. Just getting it in place.
But a durable power of attorney, you do.
You do, yes, absolutely.
Because you go to any bank or any financial institution,
you definitely need that durable.
That's just scratching. That's the tip of the iceberg.
Yeah,
they're going to
on the financial side,
they're going to want
absolutely.
Lots, with all the fraud out there, they're going to want a lot more.
Thank goodness, actually.
It's their job.
To protect, yes.
Something as simple as a will, for example. In California, if you don't have a will, all of your estate goes into probate. And typically in probate, the state's going to garnish about 30% of it, and then the rest goes to family. So completing both a will and a power of attorney and a POLST form may cost you $200, $300.
Right.
But even if you own just a home or just a car, all that, if not placed in a will go to probate, and it takes months to get it out. So
that's an incentive to get busy.
That's a big incentive to that.
Absolutely.
Well, not only time, but then a margin, and so it becomes even less valued.
Right.
Because it's devalued over time and devalued by the state's margin.
Yeah, if your family's going to give you $1,000, $300 of it's going to the state and probate, just because you don't have a will.
And that may make them motivated to get their ducks in a row and get all of their legal documents going. Doctors, thank you so much for your time today. Really appreciate it. And what an important subject. We'll continue this conversation again.
It was fun. Thank you.
Yeah, thank you.
Yeah.
Thank you very much.